doing this because this is something new which we have started, and we started as I have already discussed earlier that we have started this with the thought that when you people are coming here to dissect or observe, you should your memory about the temporal bone and the various procedures should be fresh, and you should be self-reliant when you are dealing with the temporal bone. So I would like you to, whether you want to tell us here or you want to convey us through the email or on the WhatsApp group which we have created. So I would sincerely like to know from you people that whether at the first place whether you people are liking it or not, and if you are liking it, then what part or what particular thing which you are liking, and if like we are missing on few things, that is the most important thing which we would like to know, that what we are missing on, where would you like us to improve in our further courses, because this is a learning experience for all of us. So with time the methodology of teaching and training evolves, and it should evolve. So like when we were resident, we were totally dependent upon what we were seeing in the OT, and few of the times rarely we would get few of the CDs. Like when I was resident, so the only live thing, either we would be seeing the fast surgeries in the OT, or we were repeatedly seeing the this video cassette of Dr. Stamberger operating upon a cadaver. But now the time has changed. We all have access to whatever surgery we do want to see. In fact, from whatever university you want to see, it's most of the time it is available. So we have also evolved with the this learning method. So I would like all of you to please sincerely speak out, or at least tell us through the WhatsApp or email that what all you would like us to improve in our future courses. Thank you. I think we should start, Dr. Utkal.
Okay, okay.
Dr. Manoj has joined. Dr. Manoj sir has joined. अच्छा. हाँ ठीक है. In the meantime, we'll go on, है ना?
Should I
ठीक
start?
है. Doctor, so with the anatomy, Dr. Motasim Ahmed, he is faculty with us at AIIMS Bhopal. So he'll be briefly revising the anatomy of the facial nerve as it relevant to the temporal bone. Dr. Motasim,
Good
over
evening,
to you.
everyone. Myself, Dr. Mohtashim Ahmed. Today, we are going to discuss about the surgical anatomy of the facial nerve. The topic will be covered under the following heads: its intracranial part, intratemporal part, that is meatal, labyrinthine, tympanic or vertical segment, and its extratemporal part, which it gives different branches to the terminal branches or posterior branches, like posterior auricular, now to posterior belly of digastric, and now to stylohide. So first of all, the facial nerve, after coming from the lower part of the pons in the form of sensory or motor root, we all know that by their nuclear origin from the pons. So there are different four nuclei are there, like motor nucleus, lacrimatory, spinal nucleus of trigeminal, superior salivatory, like this. So after emerging from the pointomedullary junction, first of all, it will go to the internal auditory canal. And what is internal auditory canal first? It is almost 1 centimeter in length, which runs in a lateral direction. From
Okay,
where
Motasim, Dr. Motasim, just a minute. Have you changed the slide, or you're on the first slide?
I am on the first slide, course of facial nerve.
Okay.
So first I will describe the internal auditory canal in brief, then different parts of the this facial nerve in different segments. and after that I will cover the branches. So what is internal auditory canal? It is 1 centimeter in length which runs in a lateral direction from the cerebellopontine angle through the petrous part of the temporal bone. When we know that the long axis of the canal lies with the long axis of external auditory canal, it is clear. But at the lateral end, we know that there lies fundus, and horizontal crest is dividing this part into two segments, means two zone. One is the upper zone and second one is the lower zone. And we know that from the upper zone, the superior vestibular nerve and facial nerve passes, and from the lower zone, cochlear nerve and inferior vestibular nerve passes. Then come to this is just short in that is the intracranial course. Second one is the intratemporal course of the facial nerve. So this part of the facial nerve is present within a bony canal, and we know that this bony canal, this part of facial nerve is divided into three segments mainly. That is labyrinthine segment, then tympanic segment, and mastoid segments. So we are mainly concerned with this passage of this nerve through these segments. So first is the labyrinthine segments. We know that it is the thinnest and shortest segments of the facial nerve. Its base runs from the medial to lateral and from fundus to geniculate ganglion. And this segment lies.
I am sorry, but I was trying to upload that image that they gave me, but it's coming inverted, so I'm not using it. It's okay. That's why I wasted some time.
Sure.
I'm sorry. So please go ahead. Huh? Oh, really? Oh, is that how it is? Then I will use that. Thank you.
Okay, sir. Thank you. Thank you, sir.
So as far as the labyrinthine segment is concerned, it is the thinnest and shortest segments of the facial nerve, which lies between the cochlea anteriorly and vestibule inferiorly. So, and its base runs from medial to lateral side from fundus to geniculate ganglion. So we know that anteriorly there is a cochlea, posteriorly there is a superior semicircular canal, inferiorly vestibule, and superiorly thin plate of bone separating it from the middle cranial fossa. And we know that this geniculate ganglion mainly contains the cell bodies of the all sensory fibers. And first branch which is coming from the geniculate ganglion is greater petrosal nerve, which is going towards the pterygopalatine ganglion through the great with the incorporation with the deep petrosal nerve. So we all know that. But this segment is the narrowest part of the facial nerve, and it is susceptible to compression by means of edema. And also one important thing is here is that it lacks anastomosing arterial arcade. That's why it is also vulnerable to embolic phenomena or vascular compression. Which one? Labyrinthine segment, which is very narrowest part. So after labyrinthine segments, facial nerve changes its direction and to form the first bend, that is the geniculate ganglion, and it is mainly marked by the processus cochleariformis. Then come toward the second, that is the tympanic segment. As far as the tympanic segment is concerned, it lies on the medial wall of the tympanum, and the beginning is marked by cog superiorly and cochleariformis process inferiorly. And it is also called as a fallopian canal, this shell of bone. It extends from the first genu to the second genu. So there are two types, genu. One is the first genu at the geniculate ganglion. Second one is up to the, this is the tympanic segment. As the nerve, underneath the nerves, it takes slightly inferior course under the protrusion of lateral semicircular canal. So underneath the nerve, what happens? There lies promontory and oval window. So this oval window and promontory lies underneath the nerve, When the nerve reaches oval window, it changes its path, means it inferiorly forming a second genu which lies within the curvature of lateral semicircular canal. When the nerve reaches the level of window, again it will form second genu. So first genu is on the upper part, and second genu here where the tympani there is a start of mastoid segment after the second genu. So this is the mastoid segment which is medial to the short process of incus and nerve courses downwards. Second genu is nothing but it is a uh, demarcating point of the beginning of the mastoid segment, and this genu is lateral and posterior to the pyramidal process. What is pyramidal process? It is present in the posterior wall of the tympanum. Here there is a uh, uh, stapedius muscle is arising, and nerve to stapedius is also going through this pyramidal process. So, and it is marked by the short process of incus. Then, after the pyramidal process, the nerve continues vertically downwards. We can see here, this is the FN bracket M, that is the mastoid part of the facial nerve. In the lateral side, there is a lateral semicircular canal, and here this is the DR means digastric ridge. So this continues vertically downwards along the digastric ridge to exit through the stylomastoid foramina. We know that the mastoid segment is the longest part of the intratemporal course of the facial nerve. It is approximately 10 to 14 long, and during mastoid surgery, what happens, the facial nerve is commonly injured at the pyramidal turn. So we should know these segments clearly. So this segment is traced from where it is traced from second genu to the anterior edge of digastric ridge, we can say, where the stylomastoid foramina lies. And at this level, the pyramid lies few millimeter inferior to the short process of incus in the mastoid segment. Just you remember. And why this segment is important? Because the relationship of this segment to the tympanic annulus is important in external auditory canal surgery. So this point segment is also important. The ampulla of the posterior semicircular canal lies medial to the mid portion of this, means this mastoid segments, which is forming a useful landmark in the trans labyrinth surgery. And lower part is centered on the lateral surface of the jugular bulb. So in the lower part there will be a jugular bulb. So at the level of pyramid, we know that there is a process which through this the nerve to stapedius is arising from the descending part of the facial nerve in the posterior wall in the mastoid segments. So second nerve, first nerve was our at the level of genu, that was greater petrosal nerve. Then second one is after going towards the second genu, then vertically downwards, it will give rise to this nerve to stapedius. Then further downwards, the chorda tympani is arising from this part. So it is which between the lateral semicircular canal and stylomastoid foramen. So there are two branches in the posterior wall.
Hello, Dr. Motasim. Hello.
I think he must have lost the internet or something, no? Because it has gone, it's just frozen and his voice is not heard.
Yes, sir.
We are stopping that.
I think.
Okay. Is my video clear? Is the picture inverted or is it real?
No, no, sir. Yeah.
Oh, because it is seeing inverted to me, so that's why. Yeah. So once again, thank you so much, AIIMS Bhopal team, especially Dr. Amit and everybody here who invited me over to this talk. A special thanks to Dr. Manish Grover, who actually I think introduced me to you.
Yes, sir.
My good friends are here in this course as well. It's a pleasure to be here. And just a question: the people who are listening are mostly postgraduates. Okay, good.
They are into early
So
private.
okay, so we are going to be talking to slightly a little bit of juniors, so people who are slightly inexperienced. I will take that into consideration when I am giving my lecture. So can I start presenting
Sure,
now?
sir. Sure. Sure.
So is my slide visible to you all? Okay. So dear friends, my module is about canal wall down procedures, which should ideally be a continuation from Dr. Mothusin's talk. So now that there's been a small hitch, we shall go through that and I shall try to fill in about what he already talked to you. My slides are moving, I suppose.
Yes.
Yeah. Okay. Now, in this topic, I would deal briefly with the following things. One would be how to define and classify this particular thing, and how to define anterior posterior butters, which I think he has already gone through. So we shall go through that as we are giving the talk. When would we be doing it? What are the advantages and disadvantages? What are the operative steps and tips and tricks, and how to do a good canal wall down surgery? And most importantly, how to avoid facial nerve surgery. Tips to avoid cavity problems we shall be dealing along with the operative steps, and how to manage certain complications that happen during surgery and after. Now, what is a canal wall down procedure? Canal wall down procedure essentially is a surgery for cholesteatoma. See, a cholesteatoma, as you know, that though we call the term as a misnomer, the oma process of that of a tumor, it actually applies to the disease. The cholesteatoma actually extends beyond what you can actually see. So it makes sense for someone to be operating, when you're operating for cholesteatoma, to remove more than what is um, seen by your naked eye or through the microscope. Now, that means that when you're doing surgery for cholesteatoma, it makes sense to remove everything there is in the middle ear, which means removing the posterior canal wall, all the structures, taking out the cells, and leaving only those things that are important, which would mean the middle ear structures that are needed for hearing, the part of the tympanic membrane, the labyrinth, and the facial nerve, obviously the cochlea. And of course, we would like not to go anywhere near the carotid or the jugular sigmoid sinus. So, in a canal wall down procedure, the posterior canal wall is removed and everything is made into one single cavity. In contrast to the intact canal wall technique, where you would try to do all this but retain the posterior canal wall. Everywhere where I go in India, the term modified radical mastectomy is still used. And this term is technically incorrect, because modified radical mastectomy is actually a procedure where you try to remove most of the tissues that you see in the middle ear and mastoid cleft, without doing anything to the tympanic membrane or the ossicular chain. So, when you do a canal wall down surgery, you would actually do a modified radical mastectomy, but that is not all of the surgery. It is combined with the previous thing that I mentioned, tympanic membrane being reconstructed, and with ossicular chain. Now, what is the indication? As I said earlier, the primary indication for a canal wall down surgery would be cholesteatoma. But you would also do it as an approach to tumors. For example, if you have a tumor at the external aortic canal, you have to do a canal wall down procedure. And also for paragangliomas, what we call the glomus tympanicum or the glomus jugular, you would like to do a canal wall down mastectomy, and sometimes turn the facial nerve around to make sure that you see everything that is there in the floor of the middle ear. And also, if you have a dead ear and if you want to do a surgery later for cholesteatoma, some people say that it would be good for all dead ears with the chronically discharging dead ear to do a canal wall down and do a subtotal pituitectomy and do a blind side closure so that you can do a cochlear implant later. Now, what are the advantages of canal wall? Obviously, when you do a canal wall down procedure and remove the complete posterior canal wall, you would look at the middle ear cleft from all sides. You saw Dr. Motasim's picture where you see the posterior canal wall and the facial nerve and the pyramid, the slide where you stop. If you take the canal wall out, you would see obviously everything in the middle ear cleft. The hidden areas in tympanic membrane, the supratubal recess, the sinus tympani, hypertympanum, and the retrofacials are clearly seen when you take out the canal wall. Even after surgery, if you want to look at the cavity, see how it is, post-surgery visualization was easy. And there is theoretically a lesser chance of recidivism of disease when you do a canal wall down procedure. But what are the main disadvantages? When you do a canal wall down procedure, obviously you're creating a larger cavity, however much you try to obliterate it, but there is clearly a difficulty in fitting a good hearing aid. Also, when you do a canal wall down procedure, because you bring down the posterior canal wall, there is reduced middle ear height, and they would be technically poorer hearing due to less middle ear height. It also makes fitting of a prosthetic device like a TORP or a PORP very difficult when you're doing a canal wall down procedure. However good you are and however accomplished a surgeon you are, you can never say that your canal wall down cavities don't need maintenance. It may not be that, like in the older days, you would say they remain wet. They don't remain wet most of the time, but they do need periodic cleaning, removal of wax, because the wax does not come out of a cavity when you do a canal wall down procedure in many cases, not in all cases. People who do water sports may be very difficult to do a canal wall down terminoplasty because water and cold water, especially entering a cavity, can produce a disease symptom labyrinthine stimulation. And you cannot get into some jobs like the Air Force or the Army if you have a large canal wall down cavity, even if it is obliterated. Now, what are the operative steps that you do to perform canal wall down? I divide it into three parts. We call it plan, perform, and finish. How do you plan? You plan by doing a proper meatoplasty, you harvest cartilage, you saucerize the cavity completely, you clear the sinodural angle, you skeletonize the sigmoid sinus, you identify the digastric ridge, because these things prepare you to perform your surgery. And what do you do surgery? When you remove the perilabyrinthine cells, you lower the facial ridge till the nerve, you do an atticotomy, you open the attic, you disarticulate the incus, amputate the malleus head, you clear the supratubal recess, you remove the anterior buttress, and this makes sure that the disease is gone. And by finishing, you do a canaloplasty to visualize the annulus, to examine all the areas that you may have missed. I'm sorry, there was a repetition there. You clear the disease around the stapes foot plate and obliterate the cavity, do a cartilage support for the middle ear, and do grafting and closure. Now, what is the first step? See, when you do a surgery, and this is what happens when you do a surgery, you actually examine the ear and clean it through the microscope using a speculum. So here you can see that there is a cholesteatoma inside a cavity. I'm made it very short so that we don't unnecessarily prolong this talk. You can do a post-oral or an end-oral incision. I will come to the end-oral later, but the stock procedure being post-oral, we would like to do this thing. So here we are going to do an incision on a person who has had a recidivistic cholesteatoma, operated twice before, the cavity is still discharging. So here what do you do is that you take a Bowie knife by unipolar cautery and make an incision and make sure that you are going above this area here, which is the post-oral soft tissue, so that you can create your flaps for doing surgery. Gone are the days when you used to make huge, you can see already here the scar of the previous incision down below. Gone are the days that you do a huge incision for a canal wall down procedure. Generally, an incision that starts from where the pinna leaves the scalp to slightly above the masseter tip would suffice for most procedures. Now, how do you harvest a graft here? See, graft harvest is done by, there are many ways. People say that, you have to take the temporalis fascia or the tracheal perichondrium, but I just want to introduce one concept that you can actually use the postoral soft tissue, and the periosteum, here in this case, scar tissue for harvesting a graft. Here you can see what is being done. So you take a small non-tooth forceps, and with a sharp 15 blade, you can slice away a part of the scar tissue there, and make sure that you get a decent graft for doing surgery. So this is all that is needed. So you really don't have to go high up above and take temporalis fascia. And you must understand that when you take temporalis fascia, you do cause some amount of pain due to muscle movement. I mean, this is just an option. I'm not saying this is the only way to do it. Now, you have to prepare the ear for surgery. So what do you do here? You make sure that you take a large palva flap. I tend to use a posteriorly based flap. You elevate the canal skin anteriorly and inferiorly, superiorly. Remove all the soft tissue that you might find there that is in the cavity. And there you are now prepared to do a surgery. Now, immediately when you look at this, the reasons for failure of the surgery are very obvious. Now, one is that this area is not saucerized. You are seeing an area that is below that. So there is a small ledge, and it is not clearly not a saucerized cavity. You also realize that posteriorly, the canal wall has not been, the mastoid cavity has not been lowered down to the level of the sigmoid sinus. Looking anteriorly, you clearly realize that the facial ridge is not lowered. So these are the reasons why surgery fails. Here in this case, operated twice. Now, then we have to do saucerization of the cavity. So how do you do saucerization? You take a large burr with copious irrigation, and then keep on cutting bone with gentle strokes of movement to make sure that the bone is sloping into the cavity. And this is extremely important. So people have I talked about this so many times, but see here, you can see here, there's actually a large cell here behind the sigmoid sinus that has not been operated. So, here, a lot of cells are still remaining open anteriorly, superiorly, superiorly. That's a sinusoidal angle, inferiorly, and we go right down. See, you can see the facial nerve line there. There's still a lot of posterior vertex is not removed. So here, you can see at this area there is still a lot of bone left behind, inferior to the tympanic annulus. So that also has to be removed. So here, when you do this, you can see the facial outline here. You can see the fibers of the digastric. See, this is very important. So when you look at the mastoid cavity, the posteriorly is the sigmoid sinus that goes down, reaches the digastric, and the digastric goes anteriorly, and the fibers of the digastric muscle go towards the facial nerve. We have always talked about the digastric ridge and the digastric ridge, but very rarely do people actually identify the structure. So if you see the fibers of digastric here very clearly, you know that here would be the facial nerve canal. So that's the most important way to identify. So those people who have seen parotid surgery would realize that when you're doing parotidectomy, what do? You actually follow the digastric backwards, and as the digastric attaches itself to that area in the mastoid tip, you would see the facial nerve just superior to it. The same thing happens here, just that you're going backwards. Now, now we have to be clear in the middle ear. Now, here, obviously, there is a lot of disease there in the middle ear. That all has to be removed. So, I am still leaving this part of bone here, which is the posterior buttress. This is what Dr. Motherson described. And then most of the disease here, anterior to the pyramid. See, the posterior limit of dissection in a cholesteatoma should be the pyramid. Dr. Motherson did mention to you, because pyramid comes anterior to the facial nerve, and from that would arise the stapedius tendon, and which lead on to the stapes foot head. So the dissection that you saw here obviously the stapes is absent, but I am just doing dissection in the line of the stapes, that if in the rare event the stapes is present, I would not be disarticulating it. So that is the middle ear work in very short, for want of time. Yeah, I'm not going into much detail here. Now comes lowering of the facial ridge, which is the fear of every learning otologic surgeon. Not only learning, but even people who are senior. Now, what we do here is that once you see the posterior buttress, see this is the posterior buttress. I shall stop the video here a bit. So this is the posterior buttress. This is the lateral semicircular canal. Now you have to understand something. That there would be the horizontal facial nerve. We have not seen it yet. So when you can actually touch and see the horizontal facial canal, which would just be posterior to the cochlear process here. So if you look at the lateral semicircular canal like this, as a structure like this, if you divide it into half, anterior to the middle of the this line, anterior to the midline, the facial nerve is always below the lateral semicircular canal. At this point, the facial nerve would come to the level of the lateral semicircular canal, and here it would be superior to the lateral semicircular canal. So even though we look at these anatomy drawings and find that it makes a curve, the curve is hardly a curve. It is actually an elevation and a curve, which is something that you have to realize. So we use a large cutting burr. Cutting because see when you see what is happening here. When I'm using a cutting burr, I'm actually opening up the cells. So that would be the chorda tympani here. You can see it. I shall stop it once again. See, this is the chorda tympani joining the facial nerve. So if you are drilling here, if you drill anterior to the chorda tympani, nothing will happen. But posterior, you got to be careful. So once again, going back, we are using a large burr in the direction of the facial nerve, drilling with smooth strokes, very smooth, opening up all these cells. It has always been mentioned that you use a diamond burr around the facial nerve, which is actually not true, because if you use a diamond burr, you tend to produce heat-induced damage. So here again, by the time you finish your surgery, you're seeing the facial canal here. Once again, the fibers are digastric muscle joining here. And here you can see the faint outline of the digastric muscle, the digastric ridge. So everything lateral to this is unnecessary. See, now this patient has got a large mastoid tip. Now, if we leave this and graft this patient like this, what is going to happen is that this is the floor of the middle ear, this is the mastoid cavity, and there is always going to be a sump. So what do we need to do now? We need to take away this tip. The technique of amputation of the mastoid tip is something that is very often mentioned, but very rarely done. We shall deal with it in the next slide. Now here, I'm going to talk about the digastric. So this is what happens. So that is the digastric muscle. So we use a large burr. Now here a diamond one to thin that out. Can you see that here? Thin it out. And as I am, that you can see the mastoid tip coming out. So we can use a Bowie knife and then completely remove the mastoid tip. See? Now what has happened is that this digastric muscle is going to collapse into the cavity, and there will be no sum, because here the middle ear height and the mastoid floor height will be one level. Now once this part is over, now you have cleared up the sinodural angle, which is between the sigmoid sinus and the middle fossa dura. You have cleared out the digastric ridge, you have taken away the tip, you have seen the facial nerve. Now we got to go onto the attic and the anterior buttress. So here what we do is that we need to be, I'm sorry, this is a slight mix up of this video here, but it will start soon. So we remove the digastric ridge, and then once that is done, we are using a small cutting burr to take away the anterior buttress. So that would be the anterior buttress. Now the anterior buttress would separate the mesotympanum from the epitympanum. Now here would be the eustachian tube. There would be the carotid canal. That in the middle would be the semicanal for tensor tympani, and the structure above that would be called the supratubal recess. Now you must understand that if you see the cochleariform process here, there will be no facial nerve anterior to the cochleariform process. What you see anterior would be the semicanal for tensor tympani muscle. So if you are having a cholesteatoma here, any amount of drilling anterior to the cochleariform process will not damage the facial nerve. We shall show that to you in another video if we have time. So now, so that is what we are doing. So you can see here, that's the eustachian tube opening. So once we drill away the anterior buttress and open up the supratubal recess, there will be one smooth cavity from the eustachian tube area, that is the mesotympanum, to the epitympana. So healing of a mastoid cavity will only happen if there are no big ups and downs inside the mastoid cavity. So that is why attic clearance is so very important. Now, after this is done, we have to harvest cartilage. Now, there are many ways in which people do it, but I am mentioning about what I would do. So we tend to harvest cartilage. So a lot of cartilage can be obtained. So that is the congal cartilage there, can be taken by a sharp knife, and that is removed. We also take some cartilage from the part here, there, and also from the floor. So here now we already fashioned it. So that's a floor cartilage. So these cartilages can be used to reconstruct the middle ear and also to obliterate the cavity. So if you don't do it properly, you are not going to, two things will happen. One, the middle ear height is going to be shallow because of no cartilage. Healing, the drum will go plaster itself onto the middle ear. And also you may not have enough soft tissue support for the obliteration that you do. And thirdly, with the cartilage here, you will never get an adequate meatoplasty. So this is how meatoplasty is done. So what we do here is that we are making a cut here, suturing the inferior portion inferiorly, anterior portion anteriorly, and superior portion superiorly. So that is the area where the congal cartilage is removed, and that is also sutured. So now we have a skin-lined meatus, which would allow the skin to grow like that into the cavity and to the floor and outside. And there is no cartilage exposed anywhere, because cartilage exposed means there will be granulation and discharge. That's another one of the complications of a mastoid, canal wall down mastoid surgery. Now, once this is done, we have to turn back into the area that we have prepared. We have made a nice cavity, we have removed all the disease, we have cleared up everything. Now we need to use some cartilage area. So what we do here actually is that, so that's a remnant tympanic membrane there, which we remove whatever is diseased and leave only the mucosa, some kind of interlay. This cartilage is sliced and placed on the middle ear. Another part of the cartilage is placed in the attic, and there is a little extra support in that area where I feel the cartilage is deficient. So here what is happening is that now we have an area, a cartilage that is flush with the facial nerve, sitting on the TM remnant, that is the mucosa part of the TM membrane. The skin, of course, has been lifted away. This is some kind of an interlay procedure. So the cartilage sits on the mucosa. Why this is important is that when the mucosa is exposed outside, there will be mucosalization and discharge from the ear. So you try to limit that by keeping a cartilage over the mucosa. So that's a cartilage support to the ear. The next would be obliteration of the cavity. Many people use different ways to obliterate. People have done, I mean, if you just search obliteration, you will find thousands of papers in many ways in it. You kind of some Hong Kong flap and this flap, that flap, temporalis muscle superiorly based, inferiorly based. I would not say they are all bad or good, but each of them have their own problems. What I tend to follow is by using bone pate. So when we are drilling, we actually collect this bone, the drill, as long as there is no cholesteatoma, mix it up with fibrin glue and use it to obliterate the cavity. So here what we do is once you are finished, you have a cavity that is much, much, much smaller, and the bone pate completely filling this area. That is a cartilage support of the middle ear. It sits on the facial nerve, and you find no ups and downs here. You have a small little cavity, which obviously will shrink a little bit over time, but still you will have a cavity without much ups and downs. And now you have to do grafting. So you have already taken that soft tissue which you have thinned out and dried, and then we would use this tissue to sit on the cartilage, and you would return the skin over that graft. So now here I shall stop it. So this is the graft, that is the skin. So what we have the mucosa, then we have the cartilage, and then we have the graft, and then we have skin. See, when you do that, this skin would grow across the graft, and there would be no mucosa here. I mean, at least from your naked eye, you can never never say no mucosa, because it may still be present in very small quantities. But this would pave the way for a relatively trouble-free cavity. So I shall start the video once again. So we are using a cartilage. So there you can see some cartilage here. Fibrin glue is used to make that stick. And then we use pack that area with gel foam, and then the wound is closed. So this is how it looks. The posterior palva flap is sutured back to the temporalis muscle and to the digastric here. So you have this area closed. That's the operated cavity that is obliterated. That's a myotoplasty, skin growing across. So see here, you know what? See, now, when you look at the CT scan here, I mean, I should try jog your memory for those people who are not very familiar. That's a basal cochlea. I'm sorry, that's a basal cochlea. That's the internal carotid artery. That's a eustachian tube. Here is a facial nerve. Now, this cavity is always going to have problems because, see, that's a tympanic membrane. Now, if you don't remove this facial ridge, however neat the cavity might otherwise be, you would still collect debris here. Can you see that? So this is something we have to avoid by going down as close to the facial nerve as possible. You are never a complete surgeon till you can actually go close to the facial nerve but not see it. So here again, that's a lateral semicircular canal. The cavity which was otherwise well properly done is only being hampered because the surgeon was afraid to go near the facial nerve. So that's the facial nerve, the geniculate ganglion coming into the horizontal segment, passes below the arch of the lateral semicircular canal. That's a vestibule. That's a little dot of the posterior semicircular canal. So here you can see that in this side, an intact canal wall tympanoplasty was done. This side also intact canal wall tympanoplasty, and this is the difference between what we showed you just now, a canal wall down, vis-a-vis an intact canal wall, which would be obviously another topic. Now, I shall show you some ways in which you can prevent injury to the facial nerve. Here, we have a very large labyrinthine cholesteatoma, profound hearing loss. So we have done a blind sac closure of the external aortic canal. We have gone into the ear, and there is cholesteatoma everywhere. The same principles of the last surgery apply. You have to saucerize the cavity. Just because you obliterate, it doesn't mean that you can be callous with your cavity. So here, that's a facial nerve. It is now lying much anterior. It should have been here, but it's gone there. Can you see that? See, that is a facial nerve. This is a lateral semicircular canal. That is a facial nerve. This facial nerve has been pushed anteriorly because of cholesteatoma. A patient presented with facial palsy. So this is the labyrinth that is eroded, complete erosion, and the facial nerve pushed anteriorly. So what we have to do is we'll have to remove all the disease, do a labyrinthectomy, and tease the cholesteatoma completely away from the facial nerve, do a complete canal wall down tympanoplasty, and do a proper labyrinthectomy and make sure that all the disease. So you can find here, there is cholesteatoma below the facial nerve as well. See, that is the cochlea being opened. That's a lot of perilymph gush that is happening. So we have to clean up that area with and keep some Surgicel. So we are dissecting inferior to the facial nerve. So now you have, at the end, you have this entire facial nerve, which was actually here, come back to its original position because once you remove the cholesteatoma. So here there's a labyrinth completely removed, cochlea opened, now sealed off with Surgicel and fat. That would be the area of the petrous carotid canal and all the disease. See, that's the gush which is now being plugged off with soft tissue. That's a cochlear module is being opened, all because of cholesteatoma. And then at the end of the procedure, we would pack off the eustachian tube, put some glue and abdominal fat and close it. This patient, 6 months later, obviously had a partial facial nerve palsy before surgery. Immediately after the surgery, complete facial palsy. And actually, coincidentally, she came today and has got complete recovery of facial nerve function, as long as you maintain the complete sheath. Now, here again, a small thing about what you do when there is a lateral semicircular fistula. So here, when there is this an endoral procedure, so when you have a fistula, the matrix till the very last moment, and after everything is over, when you remove the disease, that's a malleus being nipped away, and see that area. Wait a minute. See, here is a lab semicircumferential fistula. That's an endosteum being opened, and here we are removing some of the disease around the stapes with use of a laser, and then the same technique is done of grafting over the mucosa and under the epithelium, and again obliterating with bone pate. Now, how to avoid an iatrogenic facial palsy? So here I will show you a small video of what happened. This surgeon, let me stop here. This surgeon actually opened up here. That's the incus. Now, even though most textbooks mention that the short process of incus is a relationship of the facial nerve, you must understand that a short process of incus only points in the average direction of the facial nerve. It is not even close. People who do cochlear implants will know how far away the short process from the incus, from the facial nerve. So here, the actual mastoid was here, which was not being opened. We opened up into the attic, went through the incus bridge and hit the facial nerve. So here we are trying to do a proper mastoidectomy and find that there is a facial nerve that is completely exposed at this point. Can you see that? So Dr. Motasim actually mentioned in this talk that the most common area of injury would be the pyramid. So here is where the horizontal part turns into the lateral part. I told you here, this is a lateral semicircular canal. In the middle of the lateral semicircular canal, the facial nerve comes to the height of the lateral canal and then on comes superiorly, where it lies superior to the ampullary portion of the posterior semicircular canal that you see here. So that is what we're doing. We are actually decompressing the facial nerve completely and making sure it is all exposed. So when you find less than a 25% damage to the facial nerve, you don't do any grafting because you can get nothing better. So we have actually tried to do a proper tympanoplasty for this patient and put some steroid soaked gel foam over the exposed facial nerve. And this patient had an almost normal recovery of. Now, a small little thing about endoral approach. You can do the same thing endorally too, whatever we have done. So in the endoral approach, you incise under the retractors. There's a very small incision here. You get an excellent end-on view onto the ear. But in general, I would do an endoral procedure only when the pars tensa is intact, because reconstructing entire tympanic membrane was actually difficult with a endoral approach. So we start off with a smaller burr in contrast to a canal wall down procedure. So you go near the attic, start off with a smaller burr, and then come back. So this is what is called inside out procedure. You can see here, see that is the stapes. So the incus is now being disarticulated and removed, and the epitympanum is now opened. That is the supractubal recess that you mentioned earlier. The facial ridge is completely lowered till it is again flush with the facial nerve canal. We shall show you some landmarks after that is being done. We take a large tracheal perichondrium off and take off the, I shall show you a few things here. 1 minute. So here we saw Dr. Motasim describe a few things. That would be the pyramid and the stapedius tendon. That's a stapes head with the anterior and posterior crura. That is a round window. This would be the oval window area. That is a cochleariform process, and that is a horizontal portion of the facial nerve, and that is a semicanal for tensor tympani. That would be the supractubal recess. So I hope if you had listened to his very nice talk, these things are being mentioned, but there's one thing seeing a picture and second thing actually seeing the live thing inside the tympanic membrane. Here we have cut off the malleus head, so the malleus handle is still remaining there, which is very important because we keep the cartilage there, put the perichondrium and replace the incus, like I said before, over the cartilage and the graft. And the incision is sutured. You will have only a small 1 to 2 centimeter incision in the incisura terminalis. So we have another obliteration technique. I shall quickly go through this now. So here you can actually do a large episiotomy and then take out that bone completely, and then use it after you finished a typical canal wall down procedure like before. You can place that bone pate and keep that bone back. This is another technique that is described. So you can drill the bone and keep it back to close of this area. This also I do sometimes if I can get enough bone to be grafted when you have a completely intact canal wall. So thank you so much. So I hope I've run you through the basic steps of how to do a canal wall down procedure with special focus on the facial nerve. You will never understand the facial nerve anatomy until you know the relationship between the facial nerve and the semicircular canals. And if you know that, and if you can see the nerve before you come to it, you will not make a mistake in damaging the facial nerve. Somebody once asked the famous sculptor Michelangelo, what is that? How can you make such beautiful sculptures out of a block of marble? He famously replied, the sculpture was already there inside the marble. All I did was remove what is not needed. So, like Michelangelo, like an artist, when you operate on the temporal bone, you have to see the facial nerve much before you come to it and then work around it till you are sure that it is nearly there but not damaged or seen. Thank you so much.
Thanks very much, sir. You took me a decade back when during my senior residency, almost each and everything which my professor Dr. P.P. Singh would use to say, especially these attic build-up, these kind of things which we do not listen to, we do not see very frequently. So yes, you are an otology master. There is no doubt, sir.
Thank you.
You covered almost everything which I listened to or I did see. I did practice there as senior resident for 2.5 years at UCM. You covered almost each and everything. This tip resection was like very. Sir was very fond of tip resection. Whenever, like pediatric patient, it's extensive cholesteatoma,
I know.
and he would let us do also all these procedures. So I have learned a lot of. In fact, I would credit all my pathology practice to Dr. P.P. Singh, and he for ossicular reconstruction. We all know he was like wonderful.
Oh, he was great. Yeah, yeah.
And being there, I used to follow his patients, and the results were really good. But which I learned because everyone is listening, and which I learned from him is that otology needs patience, and
Yeah,
it
it
is
does.
an art. It is an art. You have to act like an artist if you really want to give your patient results. And sir, my introduction to you was in I think 2017-18 March when I saw you operating in auto ride, if you remember.
Yeah, I remember. I do.
Jaipur, where
I know.
you performed a combined approach tympanoplasty. I was waiting. There was a panel which I had to conduct on inheritance of hearing loss.
Okay.
So I was waiting there, and I did see this. I still remember that you performed a combined approach tympanoplasty, and you followed it and with the gel foam.
Yeah,
Uh,
yeah. I
then
remember that. Yeah, I do.
and I, after some time, that was the first time I did see you. And then after some time, I listened people discussing about the Messier, where they go to learn not about only about the intricacies of surgery, but the sterilization and the antisepsis.
Oh, thank you.
So, no, sir, that is true. Matlab, it is a talking point. You, whether you know or not, but all over India, it's a talking point that how good the sterility and the antisepsis is being followed at a private center. So, hats off to you, sir. You have,
Thank you so
for
much.
all of us, you have to. taken the ENT as a very prime to a very prime spot to all of us.
Thank you so much. I'm honored.
Yeah.
Uh,
So yes,
I
sir.
hope I did not take too much time. I
No,
hope.
no, sir. It was very, very good. I think, matlab, we all learned a lot, and our delegates must be very happy. And I did tell them that they should not be missing today in any
Thank
ways.
you.
So I think there were few slides that which Dr. Mohtashim could not complete. I think
Yeah, can we ask to do that?
I think Dr. Mohtashim.
Okay. Due to some Wi-Fi problem, actually, there was some error by
I think
Wi-Fi.
I think you can complete, Dr. Mohtashim. You
So I
can
could
start.
not.
Yeah, please. I think you should
Here
finish your talk.
only
You can start, Dr. Mohtashim. You can please start from the slide where we left.
this from phone. I think I will try because laptop is not running due to Wi-Fi connection. I will try my best.
I am so scared about this Wi-Fi. I always have two backups running at the same time, so it is very difficult. This Wi-Fi will cheat you all the time.
Will try my best. From where I think
That labyrinthine segment part
from
you stopped.
labyrinthine segment was covered. Mastoid is also covered. I think.
Yeah, mastered segment going through. Yes, I think that slide you were talking, the
So
mastered segment part.
okay, okay. So about the mastoid segment, we know that it is medial to the short forces of incus. The nerve courses downwards, and in this wall, that is the pyramid lies few millimeter inferior to the short forces of incus. So we know that at this level, facial nerve protrudes posterolateral to the lateral semicircular canal, and it will putting the nerve at risk during mastoid surgery. Means at this level, facial nerve protrudes posterolateral to the lateral semicircular canal,
Can I
and we can say
interrupt
that
Dr. Motherson? Dr. Motherson, can you
yes,
please turn your phone to the other mode, landscape mode? We will see more clearly. Turn your phone, please. Will it work?
yes, yes.
No, no. Ah, yeah, better. That's
Now
better.
this one.
Yeah, that's better.
So at this level, the facial nerve protrudes posterolateral to the lateral semicircular canal. The nerve to risk during mastoid surgery, and we can say that this segment is traced from second genu to the anterior ridge of the anterior edge of the digastric ridge. We can see the FN. It is the part of the facial nerve and left side digastric ridge. So it is very much exposed to the risk during mastoid surgery in this region. This segment is traced, and what is the relationship of this segment to the tympanic annulus is also important in external auditory canal surgery, because the ampulla of the posterior circular canal lies medial the mid portion, means forming a useful landmark in translabyrinth surgery. And this segment is longest of approximately 10 to 14 apart from tympanic and this labyrinthine segment. So, to that surgery, the facial nerve is most commonly injured at this pyramidal turn, and the lower part is centered of the jugular bulb. This lower part of this segment, and at the level of pyramidal process, as I have mentioned, nerve to stapedius is arising, and just below this, or we can say that 6 millimeter above the stylomastoid foramina, the chorda tympani also arises from this part, which is between the lateral semicircular canal, and stylomastoid foramina. And we know that it exits from the squamotympanic fissure anteriorly to the anterior border of tympanic membrane. Then after this there is branches. So as we have seen at the level of genu, there is first branch, that is the greater petrosal nerve, also called as the greater superficial petrosal nerve, which goes through the canal for greater petrosal nerve, and with the help of deep petrosal nerve it will form nerve of pterygoid canal, and it supplies the goes to the pterygopalatine ganglion and supplying the lacrimal gland. So that is the first branch. The other branches from the this segment, that is the mastoid part of the facial canal, there are two nerves again, same thing, nerve 2 stapedius and cauda tympani nerve, not epidus muscle. If there is an injury here, hyperacusis occur, we know. And the cauda tympani nerve crossing between the malleus and incus and goes anteriorly through the anterior tympanic uh, canal and opens into the petrotympanic fissure below the infratemporal fossa and joins with the lingual nerve to supply the submandibular and sublingual salivary gland. So cauda tympani is the secretomotor supply to the submandibular and salivary gland, sublingual salivary gland. The other branches, communicating branch to the auricular branch of vagus posteriorly, and posterior auricular nerve, which is supplying the occipital belly of occipitofrontalis posteriorly. And these two nerves are nerve to posterior belly of digastric and nerve to styloid, also arising just below the stylomastoid foramina. And this nerve, the facial nerve, takes anterior course towards the ventromedial aspect of the parotid gland and enters into the substance of the parotid and divides into temporofacial and cervicofacial branch, which gives branches in the form of temporal, zygomatic, upper buccal, lower buccal, marginal mandibular, and cervical. So these are the terminal branches of the facial nerve, also called as the pes anserinus. I think last. So this is the surgical landmark in mastoid surgery. Again, same thing. This one. These are the surgical landmarks like processus cochleariformis anteriorly, oval window and horizontal canal in the medial wall of the this tympanum, short process of incus, pyramid, tympanomastoid suture and digastric ridge. These are the surgical landmarks in the mastoid surgery. On the right side, we have seen this diagram. Facial nerve mastoid part. Here in the lower part, this mastoid part continues as a this coming out from this stylomastoid foramina. Here round window and promontory is also seen. Posteriorly, posterior semicircular canal, lateral semicircular canal, and superior semicircular canal is also seen. And this S is nothing but the steps. For this. So this is all about my slide. Thank you.
It was good, Matsusin. Very good. Lovely pictures.
It
I
is
though wish.
Dr. Utkal has helped me very lot from
Oh,
yesterday. For it is his work, I think, because
it
I
is
don't.
yours, Utkal. You took those pictures.
Know.
You took those pictures.
Thank you.
Okay.
Because initially
Yeah, please. Hmm. Okay. See, that is because I am placing it on the mucosal part of the tympanic membrane. It should not go into the eustachian tube area. It has to see. It has to be placed over the area of the tympanic membrane, which you have actually lifted up. No, like you do internally. You take off the annulus, and you have the little small layer of mucous membrane lying underneath the your fibrous layer. You have to keep the cartilage there, which is why you have to drill till the inferior part of the canal is clearly visible. So only then will you be able to maintain that height. Otherwise, see, this patient does not have an ossicular chain. It is pointless to do an ossicoplasty at this point of time because you'll always go wrong. So what we do is once this is healed and this is dry and neat, and after maybe about a year, we would go through the canal, lift up that cartilage, and put up prosthesis. That actually gives a very stable hearing, very predictable. So for you to do that, you must have a cartilage that is, convex upwards, which is sitting on the TM remnant. I mean, on the mucosal part of the TM remnant. So you should have the cartilage, then the graft, and then the epithelium. So then you will create that mid-layer height because the cartilage will always be above the level of the annulus. Okay, thank you. Yeah, yeah, please. Thank you so much. Thanks for this opportunity. I do
thank
wish,
you, Dr.
though,
Vikas.
I do wish that because that we should encourage the PGs to ask difficult questions to us. That's something that PGs don't do. Because I don't know why they are so afraid of asking questions because there is nothing called a stupid question. There are only stupid answers.
Yes, sir.
So this is something that I always found very strange. Why people don't ask questions to us? Anyway,
Yes, sir.
I think a lot of things
We
has to change. Hmm.
we wanted we tried it to be more interactive. Actually, sir, we wanted to use the Cisco WebEx platform where we can have the polls and the questions. But
Yeah.
unfortunately, that could not happen because of some payment gateway issue.
Okay.
But
Mm-hmm.
today I was attending this MS Memorial Sloan webinar.
Yeah.
So
Yeah.
it was
Mm.
on, even on, so we could have actually done on Zoom in because
Yeah. Yeah.
we
We could have
knew,
done a Zoom. In fact, I have a paid Zoom account that can cater to 300 people. So anytime, because if you want to use it, take my account.
sir. Thank you,
Okay.
sir. Thank you.
Yeah, sir. Good evening, sir.
Good evening.
Sir, yeah, I had one question, sir. After packing the whole means cavity with bone pate, and
Yeah.
we talk about the ventilation part, sir. So, in case if by chance, though, if the recurrence occurs, how do we approach? Means, if at all after that.
No, no, no. See, the whole idea. See here, if you realize that when I did this, you found that the cholesteatoma was mostly in the middle ear. There was no cholesteatoma in the mastoid at all. This was surgery done about 3 years back.
Okay, sir.
So if you are having cholesteatoma, extensive cholesteatoma, and going into all nooks and crevices, then you would not obliterate. You will obliterate
Okay.
only when you are reasonably certain that there is no disease in the mastoid. So,
Okay,
which
sir.
is when you obliterate. So, otherwise, it is not fair to do it because you will never know. However, I mean, the same principle applies to. So, if you have a doubt, what you do is you obliterate, and then after about 2 years, you can should take an MRI, a non-EPI DW, that is non-echoplanar imaging diffusion weighted MRI, which will show cholesteatoma very clearly. So that is how it is done. So you see the earlier, see, I remember when we all started off this thing, maybe like 30 years back, there was a lot of controversy. People started saying that if you obliterate, you'll get recidivism. Nothing happens. We've been doing bone obliteration for 20 years now, maybe a little bit more than that. So nothing really happens. Only thing you must use your judgment, prudence to make sure that you are actually not burying cholesteatoma there. So if you see cholesteatoma and then you remove a little bit of a bone, 2 to 3 millimeters of bone after that, there is very low likelihood of a cholesteatoma happening in that area. I do agree there is a risk, but it's a very, very small risk.
Yes, sir. And one more thing, sir.
Yeah.
The thing about removing the mastoid tip resection, sir.
Hmm.
So, is there any other way that we can prevent the mastoid stumping that you said? Like, is there some
No,
other
see,
way?
if you have a very small sclerotic cavity and the cavity is not lower than the canal, then there is no need to remove the mastoid. But you have something like this, here you have to remove. So the problem with the see what happens is that you're obliterating, right? So you would say that why can't you obliterate the floor? But when the patient is up and walking, all the discharge comes in. I mean, in the post-operative healing period, everything comes to the floor. So if you
Yes, sir.
have obliterate with whatever you use, bone, fascia, periosteum, muscle, there is a chance that will go away. So you would always have problems with a large cavity if you find that the mastoid tip area is lower than the level of the external canal. Then you have to do a mastoid tip amputation. See, mastoid tip amputation is not a difficult procedure at all. I don't understand why people don't do it very frequently. It is extremely good. You must have heard. I mean, all the good people they have done it. It is not at all difficult. See, because first, when you go ahead, start off your surgery, you have to start off by seeing the digastric ridge. And once you have seen the digastric ridge, taking everything lateral to that is not a big deal. It is not a difficult. We do it very regularly, and like Vikas mentioned earlier, we always do it in pediatric cholesteatoma. Into the mastoid cavity and make it much smaller. It's a lovely technique, and I really don't think there is anything that can substitute that. But of course, in a very small contracted mastoid, there is absolutely no need to do it.
Okay, sir. Thank you, sir.
Thank you.
You need a very pneumatized mastoid for the to fit into this category. So Rahul,
Yeah,
what
yeah, yeah.
happens is, I think, as sir is saying, that why it is not being seen done very frequently. I think so the reasons are being, one is that people are not drilling because of fear of facial nerve. I think that's the very first point. So they do
Exactly.
not see that deep tips because they do not drill in that area. And the other one is that anytime if the pneumatization is so much, it's so deep a cavity lower than the canal, taking the tip off is always better than doing any kind of obliteration. So it always
Absolutely.
gives very better, a far better result than any type of obliteration, that which I have also personally seen.
Yeah, yeah, yeah. I completely agree. It's a procedure that is very old, but I think would seriously require a lot of you know provocation for people to start doing it. I think people should do it. See, like you said, though, it's a fear of the facial nerve. You have to come down to the digastric ridge.
Yes.
People all talk about digastric, but it's very rare that when you go around the country, listen to temporal bone workshops. Even there, people don't actually show the digastric in its entirety. You have to see it where, like I showed you, the fibers going and joining the facial nerve. That has to be seen because once you see that, all your danger of the facial nerve is gone because you know exactly. See, you have 2 points. You have the in lateral semicircular canal. There, you have the digastric ridge. This line is going to be between that. It is not going to be anywhere else. So you can actually be so very confident of your facial nerve if you see that. So I
Okay,
think
sir.
doing that would actually make you a better surgeon because one, you will not create a facial nerve palsy. Second, you can actually take away the tip without a problem.
Thank you, sir.
Thank you.
I think we can conclude now.
Thank you.
Thank you and good night, everyone.
Thank you.
Thanks.
Thank you so much.
Thank you.
Shall I leave the
Thank
meeting?
you.
Thank you.
Thank you.
Thanks, Vikas. Thanks, everyone. Thank you. Rahul.
Thank you, sir. Yes.
Bye bye. Bye.
Bye.